Bismillahirrahmanirrahim. Assalamualaikum. A very good morning, good afternoon, and good evening to everyone. So the topic that we're going to discuss is auto verification of the result. As everyone knows that we as laboratory professionals are under pressure that we need to do more with less to reduce the amount of labor and supply costs, as well as to increase our workload, but at the same time to maintain our lab runtime. Probably this is also the good reason for us to look into the benefit of auto verification. So the topic that we are going to discuss today. But go back in 2019 when we did a survey to all the Ministry of Health hospitals, university hospital, and some of the private hospital lab, we found out that only 26% of laboratories in Malaysia currently implementing result auto verification. One of the main reasons why the auto verification is not yet implemented in most of the Malaysian laboratories in view of issue related to the hospital information system, the laboratory information system that require upgrading, and mainly most of the hospitals still are non-IT hospital where the issue of data demography verification and as well as test requests still require a second verifier before result can be auto-validated or manually validated. Some also still thinking that there's an issue that pre-analytical error that may cause labs release result with the pre-analytical error, and most of the time that haven't have time to figure out it yet in terms of implementing auto-verifications. As a laboratory professionals, our main aim is to release the result, but result validation involves not only just pushing a button, but we also need to go beyond of releasing the result, but we also need to be proactive in terms of consultation and clinical liaison with our colleague that directly managing our patients in the hospital or in the health clinic. So this topic is quite valid for us in terms of to ensure that we are still competitive and ready to face challenges in the future. According to the guideline of the standard Malaysian standard ISO 15189, if the laboratory implements a system for automated selection and reporting of results, it shall establish a documented procedure to ensure that the criteria for automated selection and reporting are defined, approved, readily available, and understood by the staff. And we can also refer to most of the guideline by the CSS guideline that related to result auto verification. Mainly, traditionally, what we do in our lab that we are using mental algorithm to validate a result based on a single group of analyzed result. So this is the best time for us to identify analytical error, pre-analytical error, or post-analytical errors before result can be released. But when we talk about auto verification, it is a computer system based on criteria and logic. Logic is so important when we want to establish auto verification. It can be just as simple, could be just a delta check, and it can be a complex parameter or criteria before result can be auto verified. And the most important that this kind of system can have a highest level of consistency, and some may also be known as automated result verification. So auto verification is computer-based algorithm that can be immediate verification of result, repeat analysis, reflexive testing, addition of comments or a suggested manual step, including but not limited to manual review of the result. So today, my focus that we want to talk about some aspect of the implementation of auto verification that focusing on the biochemical test, and I would like to take some examples that how we implemented or implementing in our Penang state, where all the 6 hospitals in Penang already implementing result auto verification in all the laboratories. So basically, when we want to implement result auto verification, we must go into 3 different strategies. The first one is, of course, the planning. The second major part is the developing the result auto verifications, and of course we need to have a continuous evaluate the system. So the most important part when we want to plan it, we must ask ourselves, are we ready for the result authentication? And we must get ready all the team that involve all staff and all vendors as well as experts in the laboratory to gather all the information that required for us to set up auto verification in our lab. Second one is to have our process workflow that to understand how the implementation can be done and within time frame that required. Third one, that we have to decide whether we are ready with our software that have in our lab, whether we are going to use our own instruments software, whether we are going to use our middleware for the auto verification, or the final step for auto verification based on our laboratory information system. So this is the thing that we have to really understand. Whatever facilities or software that available in our laboratory. And the most important that we have to gather all data on the current state. So by right, if you are doing manual validation, actually that is the best time for you to understand the overall running of the lab and overall what to call that system or test that available, and for sure that 90% of the result actually doesn't require further troubleshooting. So that will give you some ideas how you are going to implement auto verification in your lab. So when we talk about data on current state, before we can implement auto verification solely, it's important for us to understand the overall workflow of the lab. We have to gather all the clinical information and clinical needs and clinical requirement, as every single test require clinical input in terms of the interpretation of the result and whether this kind of result can be auto-verified or not. Technicality, the methodology of the test, the interference of the test, anything that involved with testing of the analyte must be understand and must be compile all data that required. We also need to know how is the quality of our test, whether any of the tests can be auto-verified, or certain of the tests that you think that is a low volume test and the quality performance of the test is not that good. Probably this kind of test may not need to be auto-verified yet. To have to gather all the feedback, especially from our end user, our clinical colleague, that we don't want to repeat, or we don't want to get to get the same complaint because of certain thing that can be overcome by having result auto verification. Certain thing that constructive feedback that need to be taken seriously, it can be incorporated into our result auto verification strategies. And of course, staff need to get involved, and all the feedback and data from them need to be considered to make sure that the result auto verification process can be built up in our own setting. So each unit is very unique, each lab is very unique, so we must know the needs of our lab accordingly to make sure that the successful of implementation of result auto verification in our own lab. So the second major part is to develop. The first and foremost important thing when we want to develop auto verification rule is, of course, we need to have a logic. The logic in terms of incorporating the clinical knowledge and technical knowledge and the workflow of the lab. So based on this, we can develop our own auto verification algorithm, where we need some filters and rules to make sure that results that require further attention can be strengthened before all this algorithm can be converted into the computer code or the programming language, and to complete the auto verification program. So the important part is to understand that we must have the logic before we can have the pathway or the workflow of every of the sample to be auto verified. So there is many set of algorithm can be designed, but the most important things, the design should be suited with our own laboratories, and how extensive the design of the algorithm is depend on the discussion with the team members, and to come out with the most comprehensive algorithm in our own laboratory setting. So now we are going to the filter, where is the most important part is to know the different type of filter that we can do to make sure that results are going to be filtered before it can be either auto-verify or require manual verification. So I'm going to discuss in three different aspects. The first one is the hemolysis accurate lipemic checking or interference due to the hemolysis accurate lipemic. Second one is the delta checks and delta day, and the third one is delta range and the review range. So the three common cause of interference in clinical laboratory analysis will be hemolysis, lipemic, and natriuretic. These three important interferences need to be acknowledged, and we must gather all the information before we can start our result auto verification. So probably we need to have a spreadsheet Excel to gather all the tests available in the lab and to gather all the information for the packing inserts. What is the cutoff hemolysis index for each of the tests, and as well as iterate and lipemic. And some of the tests need to be auto cancel because if let's say the hemolysis or the lipemic have a very significant interference, or probably if let's say the interference still can be acceptable, the result should be released with a specific comment to make sure that result going to be interpreted accordingly. So this is how the Excel that we have previously been translated into the programming language, where every of the test results going to be checking with the HIL checking before result can be appear for validation or can be auto-validated. So this is an example in our lab where we cancel some of the tests if let's say the tests have a very significant degree of interference due to hemolysis. And for example, LDH is one of the tumor markers. If we don't stranded the result, probably the interpretation of the LDH as a tumor marker will be wrongly interpreted as an increase of LDH, and so do other parameters. But bear in mind that the hemolysis also can give us some information whether the sample or the patient have truly in vitro hemolysis or in vivo hemolysis. So in our own lab, we have what they call the hemolysis alerts. For every of the sample that we're going to reject, we are going to review what is the potassium level, because normal kalemia in the grossly hemolyzed samples probably will give us some hints that possibility a patient might have in vivo hemolysis instead of in vitro hemolysis, and this is a very important clinical condition that the sample shouldn't be rejected as a normal sample of in vitro hemolysis. And the same type of lipemic alert, we need to have this kind of information for us, because some of the tests require further verification. For example, we want to rule out whether there is evidence of pseudo-hypernatremia whenever the lipemic interference is so high, or even in some analyte, for example ammonia, where the lipemic index is much lower, that further verification or manual dilution required before the test can be released. So it is very important to have this is incorporated in our system to make sure that the troubleshooting can be performed accordingly before result can be released. And how about iterate? Iterate is something that unable to be controlled in terms of pre-analytical error, because this is a patient condition, but it also can give us a good indication, because we did a correlation study between the A3 index and total bilirubin. It has a very good correlations, and this is also can be part of our consistency check. If the sample is iterate but the total bilirubin is low, so it's something wrong that need further verification. And in certain cases where the sample is iterate, and for example it's outpatient department or from the medical clinic, when sample come as iterate sample but liver function test was not requested, total bilirubin was not requested, so probably we can add on the total bilirubin in terms of this can have an added value to patient, as we know that patient have jaundice, for example. So the second part is to look into delta check and delta day. So delta check basically based on the RCV calculation. So we need to have a spreadsheet of tests that are available and what is the linearity of the tests that we are going to report. This is also inclusive of the extended linearity of the dilution, and the delta day and delta check. Probably the RCB can be whether based on the absolute value or by percentage, but what we are implementing in our lab is we are using percentage, and there's no specific guideline to say how many days that we should do into the delta check. So it's up to the consideration, or consensus among team members to decide what is the best. Probably maybe can be in view of the half-life of the test, or maybe how significant tests need to be checked back for each of the tests. And this is data range that we're going to discuss further. So delta check, so this is delta check and delta day. So for example, we are using creatinine. The extended linearity for creatinine is 15 to 11,000 micromole per liter, and our delta range can be 16 to 530, because 16 is the lowest measurement for the creatinine, and 530 is actually the medical limit for creatinine. And based on our delta check calculation, the RCB is 22%, and we first use a delta day of 14 days. But this RCB of 22% actually give a very good sensitivity in terms of to capture significant difference of the result, but it's not specific enough, and most of the time the 22% will give us a false alarm, and really doesn't require further troubleshooting. So creatinine is a good indicator to know whether there is a significant difference. Either it's a clinical significant, probably that patient may have a AKI, or second one that we want to rule out whether there is a possibility of a brain analytical error. So based on this paper, that we can use a simple electronic alert for AKI if we are using a 50% increase in creatinine within 90 days. So we adopt this kind of alert in our lab. So where we put 50% of creatinine difference or increment of creatinine within 90 days, and actually we are able to capture more specific cases of significant difference of creatinine. For example, in this case, patient from SOPD, so the previous creatinine within a month now increased to 992. So this result reflect with our AKI alert, and we discussed with the managing doctor that patient came to SOPD on 3rd of August, and actually patient condition is deteriorating, and this is possibility of true AKI, and patient was admitted on the same day after we informed the result, because creatinine is not part of the critical result notification, but by having this AKI alert, we do notify, and because of our notification, patient being called, and on the same day RP was repeated and confirmed that patient have acute kidney injury based on one of the parameter in the lab, because acute kidney injury not just basically on the creatinine alone. So the third one is a delta range and review range. So when talk about delta range, that what is the result should be stranded and what of the result can be just released. So there are a few criteria can be used. Is either first one is extended linearity range, means that the range can be extended from the linearity measurement after a further dilution been done, or we just want to stranded result that exceed our analytical measurement range, or result that involve with critical result, anything that medical decision limit probably lesser than clinical result, or based on our consensus, and of course the less sensitive or the less specific is a reference range, because more and more result need to be captured. So it's very important to understand your hospital setting. Your hospital have many of such specialty, and the complexity of case is many. Probably if you just use the reference range, you still have about 60 to 70% of the result, or 80% of the results still require manual validation instead of more than 90% result can be auto-verified. So I took a file example. For example, LP, the linearity measurement in our lab is 5 to 1,200, and the extended linearity after dilution can be up to 6,000. So this test is not there's no notification, critical notification for LLP, and the reference also could be a age specific. So what is the cutoff, or what is the data range that can we use or setting in our laboratory information system? So it's very important to know that LLP, lower limit of LLP, still important. So we don't release anything low level for LP, because there are two things that need to be considered. It's either the sample have additive and contamination that cause a low LLP activities, or second one that is truly a clinical condition, for example is hypophosphatasia. So that's why in our lab we put the range of the LP, lower limit of range of LP as less than 50. So anything that less than 50 will be stranded. So for example, in this case, 23 years old female lady went to clinic pergigian or the dental clinic and found out the LP is 18. So we add on calcium verification, means that we add on calcium to rule out whether this sample contaminated with additive or not. It's confirmed it was not. There is no evidence of additive contamination with even slightly high potassium. So we giving in with the interpretive comment saying that there is the low LP could be a possibility of adult hypophosphatemia, and this require further management, further evaluation or review for this patient. So this is an example that how we can add value to our test if we have this kind of auto verification in our lab. The other thing is sodium, for example, there is no extended linearity for sodium as there is no dilution required, and the analytical measurement range for sodium is between 80 to 180, and the critical result is between 125 and 155. So what is the data range that we can set in? So most likely we are going to use our critical result level 125. Anything that beyond 125, 155 millimole per liter need to be stranded. But bear in mind that sodium also have some complexity in terms of the result could be pseudo hyponatremia in view of direct ISA measurement. So mainly in the case of hypoproteinemia or hyperlipidemia, and also this is good indicator whether we want to know if there is any evidence of random error or systematic error. So for example, in our lab we have a paraprotein alert, any evidence of low sodium, the sodium and or any evidence of total protein more than 100, the reflex of sodium verification with direct assay will be requested. So what we do that we perform the direct assay in our ABG analyzer, and we will compare whether there is significant difference as evidence of pseudo hyponatremia. So we need to have our own SOP in our lab that how we manage sample that possibility have a paraprotein alert. So it's either one is a very low level of sodium that require verification, or whenever the total protein is high, so it can be have a reflex of paraprotein that that require us to do verification on our sodium sample to rule out pseudo hyponatremia. And as well as we need to have a SOP to look into our reaction monitor of every of the analyte to ensure that the test can be reported. It's not only sodium, probably a very high phosphate, like say phosphate more than 3 or more than 4, it also should have some reflex for us to look into a possibility of pseudo hyperphosphatemia due to hyperproteinemia or due to paraprotein. So this is another good example in our lab that patient came with the diagnosis of relapsed IgG kappa multiple myeloma, and the total protein of the patient is 145, and actually the sample of this patient, the sodium is just 137. So instead of just a pseudo hyponatremia, patient also may have false normal sodium level due to the paraprotein interference. So that can cause significance in terms of management of the patient, that every of the tests need to be verified before it can be released. So the most important that we need to troubleshooting and troubleshooting, and in order for us to do a troubleshooting require a good system to strand the result, so that result that require further verification, appropriate verification can be done to ensure that the result is safe enough to be released for patient management. So the last one, when you talk about implementation, of course we need to evaluate. So when we have all the setting of the test, whether there is our delta range, delta check, delta day, our HRL interference alert, as well as any other alert that can be considered in our system based on our requirement, then we need to verify these auto verification rules. Possible thing that we can do is by doing the dry testing, where we can have more and more stimulated cases in a different scenario. But this is not that easy, because case scenario or a different scenario is too much or too many to be considered. And the other thing that we can verify based on the historical data that we have, we push back from probably from middleware to the LIS. And we also can use real samples to challenge the specific rules. So we can use either unusual abnormal patient data, our propensity testing samples, or any manipulated samples that we intentionally or we create something that intentionally misidentify patient results, so that we can capture the pre-analytical error based on the rules that we set. So this can be done before the real sample can be run, and even once the real samples runs, every single result, what we do that which we check back every single result to ensure that the system work accordingly, and the system are able to capture errors or captures the clinical condition that we want in our system. And of course, the continuation of the rules need to be evaluated. We still need to develop algorithm for the automated release. We have to verify the data set in the LIS to validate the performance algorithm on and off to see whether this is good enough. Is it the rule is too sensitive until give more or false alarm, or the result is the rules is not that specific. So this is some sort like need to be have a further verification, and we use more and more simulated result. And it require periodic revalidation of the algorithm. And of course, we want to review the performance auto verification, whether the performance is as what we target of more than 90% of the result need to be verified, or whether we should reduce the auto verification. Let's say the performance of the quality performance of the test is not that good, or whether the auto verification need to be strengthened. And the revalidation of new algorithm or criteria whenever there are any changes made to the rules. So once the new rules being set in, then these also need to be verified again. And of course, by time, then we will know whether the system is good enough, or whether the system needs some changes in terms of the algorithm. So based on this presentation, are you using auto verification in your lab? If not, why not? And all this probably may help you to think that whether your lab can have a system to start to implementing auto verification. So as I thought about logic, so we can use more logic and more rules. So it's very interesting, because your clinical knowledge, your technical knowledge can come together for you to create more and more logic. And this logic is some sort like whatever system that you plan in the or whatever system that you have in mind can be translated into algorithm in the system to help you in terms of to capture more errors or more result that require more technical or clinical attention. So other than that, we can have a consistency check, auto repair, auto comment, and many more to incorporate into our system. So I have some illustrated few cases or few samples that we have, for example, that we have in our lab. For example, for urine protein creatinine index, any diluted urines or the urine that contaminated by water, for example, can cause a significant difference in terms of the PCI calculation. So what we have that if urine creatinine is very low, then the system will reflect our urinalysis component of colors, appearance, ST, and pH. And this is also will be documented in our LIS, and as well as the report will be come out with auto comment. So for example, this creatinine result, urine creatinine is 1425. So we have performed the urinalysis that reflects and be performed, and before result can be released, they also auto comment stated that the diluted urine may overestimate the UPCI. So we give attention to the clinician to interpret the result with extra caution. So we do have more auto rules and auto comment. For example, for iron study, that we have auto comment and auto reflect for each of the condition that we set in. And for example, the tarot function test, that we are using the TSS based strategy. So we add 3 to 4 accordingly if let's say the TSS is beyond the cutoff, and the comment also appear as automated comment. So this is how is the computer programming come out as the data that as I showed you before. So the most important part in tarot function test, that whenever the tarot function test result is discordant, that probably need further evaluation. So in view of this scenario that we have in our lab, to make sure that any of the result which is discordant need further attention. So we setting rules in our laboratory information system that any of the condition that fail this condition, the result will fail auto validation and require further verification by the duty chemical pathologist. So for example, this patient is a 2-year-old boy with a history of discordant tarot function test starting from during the monitoring of the chronic jaundice patient. And the discordant TFT verification, this verified by duty chemical pathologist, being reflects in the system, and we managed to discuss with the pediatric endocrinologist about this case, and we prevent from the result to be misinterpreted, because sometimes we do receive that this kind of result being interpreted as hypothyroidism, and probably we don't want a patient to be started with syrup carbimazole unnecessarily. So that is where the rules of interpreted comment can be added on to make sure that result going to be interpreted in the correct with the correct interpretation. We also have more complex rule in, for example, our HbA1c that we're running with the HPLC method. We start use variant 2 turbo. Even during variant 2 turbo, we already set our own auto-verification of the chromatogram. I mean the HPLC C-gram, that we doesn't require our scientists to review each of the chromatogram. And now even with the D100, we are able to incorporate the auto-verification rules in the analyzer and as well in the LIS, so that only result that have a abnormal C-gram or result that have a significant delta check will be stranded. And even the chromatogram will be sent to the LIS, then the pathologist or scientist can view the chromatogram before validation can be done. So this is also will reduce a number of manual verification that a lot we can save a lot of time to do other important things rather than just to review every single chromatogram, and to improve our LTAT. The last one is the other complex thing is a urinalysis, where we setting our specific rule, because this is one of the tests that have a discordant of result or certain thing that need to be further verified, because for example, a positive protein could be interfered by others parameter. So when we set that test require, whether the test require a microscopic urinalysis or not, based on the criteria that we set in the system. And for example, this one is patient have a 3+ protein, but visible bloody urine may cause a false positive protein result. So this kind of interpretation come out as an auto comment, as well as the reflects that this sample require microscopic urinalysis, and we are now even able to report the dysmorphic RBC, where this is a very important finding that need to be reported in the report. Some clinical scientists and pathologists that fail to be perceived by clinical colleagues as medical value contributor will be at risk. So it's very important as we, the pathologists or the scientists or the laboratory professional, to make sure that we are doing much in terms of troubleshooting of the sample or the result, and also we to play our role in terms of the proactive consultation rather than just reactive consultation, to make sure that we are still reliable in terms of uh, giving our service to ensure the safety of patient. So what are challenges that we may face? Most of the time that many hospitals have the most part of challenges in terms of verification of data that enter into the laboratory information system. Second, of course, that to setting something new, even though this is not new thing, but to get more references to, because it's not as simple as to have a result to be auto verified, but to make sure that the system or software that we're going to use is actually fulfill the requirement of our lab, and to make sure that it's safe enough in terms of implementing the auto verification, to make sure that our staff are fully understand, and to teach even staff after the result been auto verified. Once the result standard, now they have to ask the question themselves, why the result standard and what further action that need for them to what the further action that they need to perform before the result can be released. And of course all these need chain management, and the other part, this is involve all parties, so that we ensure to make sure that our programmer fully understand our needs, and as well as our vendor need to cooperate with us to make sure that they're successful of result authentication implementation in our lab. So last question, why we need auto verification? Because the most important that is giving us a consistency. We improve our lab turnaround time. The patient safety is most important, because all the result will go into the troubleshooting before it can be released. We want to be more proactive measure, and it's probably the predictive medicine, and also added value in terms of the interpretive comment that required to be added in our report. And of course for opinion step, for examples, every single consultation that we make to every of the result will be documented in our system, and it can be recaptured back, and this is a part of our KPI, that every month we must have numbers of consultation need to be performed, and this is can be measurable as our workload and our professionals KPI. So the final thought, that auto verification will remove the needs to look at every result and bring the lab personnel attention to those results that require attention. This is very important in our day-to-day lab activities. Auto verification will enhance laboratory efficiency, but of course we need to state that it's not completely will replace us in the process of result reporting and decision making. So I hope that this presentation will give everyone some ideas, and will stimulate us to implement auto verification in our lab. By then, thank you.